Let me welcome my panelists. So, as already mentioned, this is a case of lung cancer, which will be presented by my resident, Dr. Sandhya. And the discussants for today will be Dr. Sabita Jimnani from Surgical Oncology, Dr. Safalta Bagmar, and Dr. Nandini Menon will be representing Medical Oncology. Dr. Naveen will be radiation oncologist on the panel, and Rajiv Kaushal will be the pathologist. So, we have a great team today. And as per the theme, we have tried to rare case because that is the theme of the conference. So let's get on with the case. So can I invite Dr. Sandhya to start presenting this?
So I'm presenting a case of a 57-year-old female who presented with history of breathlessness, right-sided chest pain and cough. She is a known diabetic hypertensive and also has a history of hemorrhagic stroke and had a history of menorrhagia for which she underwent hysterectomy. There's no significant family history or she's not a smoker or alcoholic. On examination, she had pallor and she had features suggestive of right-sided effusion. The same was confirmed by doing an X-ray which showed a right-sided moderate effusion. So here is a PET CT which was done, which showed a right-sided lower lobe upper zone mass along with pleural effusion and had multiple postal mediastinal nodules and multiple lymph nodes, mediastinal and subcarinal with moderate effusion. So we went ahead to do a pleural fluid analysis, which was an exudative effusion and was positive for adenocarcinoma. Further molecular studies were sent, which was positive for EGFR exon 21 mutation. And the final diagnosis is a 57-year-old female diagnosed as adenocarcinoma. She is metastatic disease, stage 4, and EGFR mutated with known comorbidities of diabetes, hypertension, and hypothyroidism. So her performance status was stage 1.
This is a standard presentation of a female with a lung cancer with an EGFR mutation. So I'll start with some question to Dr. Rajiv. So context to happen later in this patient. That's why I'm asking you this question. Does it matter where we do the test from, whether it is cell block or tissue? Does it really matter? Is there a sensitivity issue here? So that's my first question, Dr. Rajiv.
Yeah, so if the tissue or if the sample is adequate, so whether it is from the cell block made from the pleural fluid or if it is from the core biopsy, and if the processing of the cell block is done properly, then it doesn't matter. So for us, it doesn't matter whether it is from the primary or even from the metastatic side. Although some heterogeneity, there is a possibility of heterogeneity which we can't rule out, but based on the samples, doesn't matter.
Okay. So the message is that the sample doesn't matter as long as the material is adequate. My next question to you is whether what test would you prefer for EGFR mutation study in now considering the Indian context, because now both are available, PCR, NGS. There are so many labs doing all these things. So what would be your go-to test in this, in considering the Indian scenario?
Yeah, so although NGS is always has much more advantages as compared to the PCR, but the main limitations, one is the cost and another is the turnaround time. So if the patients, as majority of our patients, the cost is the issue. So the PCR, RT-PCR is preferred for EGFR testing because one thing is the cost is low. Second, the results you can get very quickly.
Right. I totally agree with you. So most of the time we go for a PCR, but we will come back to this again in the context of this patient at a later stage. So this patient is the commonest type of mutation. Is quite a young female Asian, so there is a high EGFR mutation positive. And subsequently, before we go on to the actual treatment, we have a
patients in metastatic lung cancer. You would consider surgery. So there are three basic indications for the involvement of the surgeon in a metastatic lung cancer case. These include patients who present with pericardial and pleural effusions, which is the most commonest scenario. The second scenario is where the patient is oligometastatic, and third is when the patient presents with an oncological emergency, such as bleeding in the central airway or has a central airway obstruction. We will stick to, for the sake of discussion and for the sake of time, stick to the management, surgical management regarding this case. So this patient has come with a moderate pleural effusion and she has complained of breathlessness. So obviously she needs thoracocentesis to give her some kind of relief from the breathlessness. But as mentioned on the CT scan findings, she has pleural nodules, costal as well as mediastinal pleuras involved. So it would be better to do an image-guided thoracocentesis. And if the fluid is more than, say, 250 ml, then it is better to put in an image-guided drainage tube, whether a pigtail catheter or a small bore intercostal drainage. So the earlier teaching that you should put in an ICD, an intercostal drain, for every pleural effusion is not applicable to every case. We have to remember that. Only if the patient has a gross pleural effusion with complete collapse, requires emergency thoracocentesis, you will go in and put in a blind intercostal drain or ICD. But the latest guidelines say that it is better done image guided, especially if you have pleural nodules, loculated effusions, or a prior history of tapping. Similarly, if you have a
thank you very much.
That also needs to be drained.
Thank you very much, ma'am. I think it's a very important message. Do still get patients where patients have got an ICD inserted for just because they had a pleural effusion, and we get stuck with that and that gets infected and patient gets into all kinds of troubles. Every patient does not require an ICD. There are specific indications. That's a very important message. Briefly, you touched upon oligometastatic lung cancer. This patient probably does not come in there, but just for the sake of discussion, can you just touch upon what you would consider as oligometastatic lung cancer, where you would want to go in and operate? What are your current choices for operating in oligometastatic lung cancer?
So like we all know from literature, oligometastatic lung cancer, which has a metachronous presentation without the involvement of N2 mediastinal lymph nodes, has the best prognosis, where survival is around 35 to 40%. If there are ipsilateral or contralateral mediastinal nodes, or if there is serous disease such as pleural effusion, ascites, or bone marrow disease, or pericardial effusion, then these are not the cases that we would generally consider for surgery. So metachronous presentation is always better. But in some patients with good general condition, you can also consider those with synchronous presentation, provided you do an invasive mediastinal staging first and you rule out N2 disease. Then you can expect the patient to do well. I hope that answers your question.
No, I think that's a very clear message, very short and sweet. Thank you very much, ma'am. We will go. I'm rushing through because of the interest of time. My next question is to the radiation in the panel. The role of radiation,
So in patients who present with metastatic lung cancer, what we would generally want to differentiate at the very beginning is whether the patient has got a polymetastatic disease or an oligometastatic disease. As the previous panelist just mentioned, so patients who have metachronous disease or patients who have no mediastinal nodal involvement and no serocell involvement are the ones who do well. A typical definition of an oligometastasis is that patients who have got less than 5 metastases without any serocell involvement. So these are the patients who tend to do well regardless of what their molecular markers might be. So I would offer palliative radiation for a patient with polymetastatic disease depending on what symptoms they have. So commonly patients who present with symptomatic bony metastasis, or patients who have got brain metastasis or soft tissue necrosis which causes some pain, we offer a short fractionated radiation to radiate. In patient oligometastatic disease, we are a little more aggressive because there is now data to suggest that patients, in addition to systemic therapy, if they receive some form of local therapy, their survival is better. So again, we would want to see the extent of the disease, the tumor burden, the volume of the tumor. And in some cases, we offer stereotactic radiation, especially if the patient has got brain metastasis or an adrenal metastasis, which is solitary or a few less than 3. If the patient responds very well to systemic therapy, then in some patients, we even consider radiation to the primary disease as well, so as to give a prolonged control over the primary.
Thank you, Dr. I think you touched on most of the things. Again, a very short and very crystal clear elucidation of the role. We move on to the medical oncologists on the panel. So, what is the first line? Would you use chemotherapy TKI alone or EGFR and TKI combination? Can we start with Dr. Nandini?
So in this patient, if she is EGFR mutant and she has access to the first line therapy, I would prefer to give the patient, if she has no cost issues, is osimertinib. If osimertinib is not available or she can't afford it, then, and she's a fit young patient, she's only 57 years old, then probably chemotherapy with TKI would be my next option if there's no access to osimertinib. Only in a very elderly, frail patient, I would have thought of using a first generation TKI. But in this kind of patient, osimertinib would be the first choice, followed by TKI with chemo.
Okay, so I think we would mostly agree with this. With if the patient can afford, we would start with osimertinib for this patient. The second choice for most of our patients would be definitely with pemcarbo. This is the data for that. There are a variety of EGFR mutations actually, and there are some suggestions that some mutations may be more sensitive, some are less sensitive. So, in this context, does the type of EGFR mutation determine the type of TKI that you use? I'm asking this specifically in the context of some data from afatinib with respect to the exon 19 deletions. So, Dr. Sapalta, would you like to comment on that? Also, considering that afatinib is now available fairly on a generic basis. So, that is of interest. So, what is your thoughts on that?
The most common mutations are on exon 19 and exon 21, who are very sensitive to TKIs. Whereas the mutation which is in exon 20, that is not sensitive to TKI and they don't do well. In that case, if it is exon 20, then in that I'll be starting on, I will be preferring chemotherapy in these patients rather than a TKI. And in rare mutations, like afatinib has already shown, there are 4-5 rare mutations in which afatinib is doing better than in as compared to other TKIs. I'll be starting afatinib in these patients, and we have generic brands now, so it is quite doable now.
Right, Dr. Nandini, your comments on this? What are the situations where you would you suppose a person has got an exon 19 deletion upfront? Would you prefer afatinib over gefinib plus pemcarbo?
Not if unless the patient doesn't want to take any chemotherapy whatsoever, then maybe in that case I would prefer. But there is mixed data. Some studies, the initial Lux Lung and 3 showed maybe afatinib did better in the exon 19 deletion, but then in Lux Lung 7 there was no significant difference. So it was a smaller study. So if the patient has a rare mutation, there is a pooled analysis. Other than exon 19 and L858, are the other mutations have shown sensitivity to afatinib. In that case, like Dr. Sapalta said, probably afatinib would be a good choice because chemo and TKI, the study had very few patients with those rare mutations. But for exon 19 in particular, I would not give an extra advantage to afatinib. So I agree with what Dr. Sapalta had said.
Right now, the message is that there is no clear data. So we stick on to the original. So this page started on first osimertinib. When report was available, after 2 cycles of osimertinib, he had kind of stable disease. So we continued on the osimertinib. Dr. Sandhya, can you take over from here? Oh, sorry.
Yeah, so this patient was started on first line osimertinib, and after 4 months of first line osimertinib, she had shown some progression. Meanwhile, we'll take up other questions. So yeah, regarding this patient, she was started on osimertinib, and we continued on osimertinib, and after 2 months, we had done a CT scan which showed stable disease, and hence we continued on it. So the next question that we wanted to ask on the experience of osimertinib as first line, and would we always prefer that over TKI with chemo?
So continuing from there, this patient had a progression after 4 months. So my question again to the panelists, if Dr. Nandini can answer this, how often for a biopsy in these patients?
So, with the availability of NGS and multiple rare mutations that we can detect, we generally after osimertinib within 4 months is an early progression, which is a little odd. So, I would like to offer this patient a rebiopsy. So, in such a scenario, probably if the patient is willing, we would like to offer all these patients, if the safe rebiopsy could be done, get a rebiopsy and look for additional mutations post osimertinib if they have occurred. For an osimertinib to progress in 4 months is odd. So, I think rebiopsy should be considered.
Interest of time, I'll keep moving on. So this patient, we did do a rebiopsy, and while the reports of the NGS was awaited, we started her on chemotherapy. But after 2 weeks of PEM carbo, there was a clinically increase in the size of the supraclavicular lymph node. Hence, we felt that it was because of the stoppage of the EGFR TKI, and then we restarted her on some TKI. So we added at this point of time, and there was a clinical reduction in the size of the supraclavicular lymph node. We also added bevacizumab from the second cycle in this patient. By the time we could get the molecular testing report, which showed that she had a mutation in HER2 in exon 20. At this point, there was no mutation identified in the EGFR. So this was the HER2 mutation, which was exon 20 of the gene, which was reported as a gain of function mutation. So we had a peculiar situation here where the EGFR mutation disappeared and we had a new mutation. So as always, we are like questioning whether the lab is good. Many lung cancer panels are available. They are getting cheaper by the day. So many centers don't have in-house testing, so we rely on these outside labs. So how to trust these reports? And sometimes they say they can do a panel of NGS for 10,000 rupees or 11,000 rupees, 15 genes, 20 genes. How do we trust this? Is it reasonable for somebody to do an NGS panel at such low rates? Can you comment on this, Dr. Rajiv?
So this question, if whether you can trust or not, this should be addressed to the medical oncologist. But I request whosoever is sending the samples to such labs which offer the low panel, the NGS panels which cover very few genes. So those panels should be very critically evaluated. And even the discussion with the local lab, which platform they are using to test them, and what is the coverage. And so you have to really go before you send the tissue to such labs. Before upfront, you should have information that how much true or reliable information you can get from such reports. And we have seen, although for some common mutations, these panels are quite good. But they are unable to offer the co-mutations or the rare mutations. So we have, as I said, we have to very critically see the coverage, the panel, the spectrum, and which platform they are using for this testing.
Actually, I am in a corporate hospital. We don't have in-house testing lab. It is like they have tie-up with other labs, and we are getting the coupons from the companies which are like providing some discounted rates. And those labs, they are quite standardized, and it is like we are using NGS actually, so that the small tissue, all the tests can be done at a time, so that we will not be in a shortage of tissue. And that's how, like, we are happy with the kind of report we are getting by it is basically from the response rates we are judging that thing, and the patients are doing good, so we are having faith on these labs.
Okay, Sandhya, if you could move on. Go on.
Regarding the patient follow-up, in view of stability of symptoms, patient was continued on gefitinib, PEM, and BEV for 5 months. And the response was done in October 2021, where it was showing a progressive disease with new liver, peritoneal lesions, and cervical lymph nodes, whereas the primary was stable. So, as we have already shown that this patient's mutation analysis was repeated when she had progressed with right supraclavicular lymph node, and that had shown loss of EGFR, but there was a new mutation with HER2 at exon 20.
I'd like to ask the panel about their choices for this patient, because now she has got a HER2 mutation and the EGFR mutation is apparently lost. So, Dr. Nandini, what is your experience with HER2 mutations? Because in TMH, you probably would have seen some of these patients definitely. So, what is your experience in treatment of these patients? What would be your choice of drug these patients?
So, HER2 mutations are quite rare in lung cancer, but we get, because of the increasing use of NGS now, they are being detected more frequently. So, probable incidence would be around 1 to 2%, not more than that of all the non-small cell lung cancers we see. Some patients on compassionate access, few patients had received positionib when they had exon 20 insertions in the HER2, and few have received TDM1. So, but limited experience with other with TDM1 and other newer drugs like trastuzumab deruxtecan, we have not treated anybody yet with that. So most of the patients either receive TDM1 or we try to get them positionib on compassionate access. Those who have no access to either, so they end up mostly on either on chemotherapy if they don't get an access to either of these drugs.
Sandhya, can you just go one slide?
One side behind.
Okay, so I think the point we wanted to convey was there are options now available for the HER2 mutated lung cancers. What is immediately available in India is TDM1 for whoever can afford it, and then there is this data from trastuzumab deruxtecan, which is also showing very promising data. Of course, costly options most patients cannot afford, but this patient could try that. But unfortunately, she had a very rapid progression after 3 months of TDM1. So these drugs do work, but they are not really, fantastic. So most patients do progress after a few months of any of these TKIs for HER2 targeted patients or these antibodies. So current status is that she has progressed now after TDM1. So any last day on how you would manage this patient? She's still keen on trying to do whatever she can. So any last take on this, Nandini and Dr. Sapalta, before we wind up?
So the question of whether to use, mostly in this patient, if she has progressed on TDM1, probably another line of chemotherapy plus minus immunotherapy. So in the Destiny Lux Lung 1, the problem is they didn't allow anybody who had received antibody drug conjugates or trastuzumab prior to the TDXD to be included in the study. So we are not very sure whether if she has failed TDM1, will she respond to another antibody drug conjugate. So I'm a little wondering whether this patient should just go on for third line chemotherapy or whether she should go on to another clinical trial if available.
Okay. What about immune therapy? Would you consider there was this data with that 4-drug combination of pacli-carbo
yes, sir.
A subgroup analysis, but
yes,
pacli-carbo
yes,
atezolizumab?
If
Any
the
experience with that?
So not so with pacli-carbo, pembro and bevacizumab, few patients, but atezolizumab, very few patients have used in our setting. Not much of experience in the HER2 positive tumors.
Okay. Any last comments from Dr. Sapalta?
Actually, we don't have much option in this patient as such. TDM has already been used on trastuzumab deruxtecan is one option. Followed by this TDM1, I don't know how much response will be there, but then immunotherapy, yes, I would like to use immunotherapy in this patient. Pacli-carbo along with pembro is one good option. That's what I am not. I don't think so. Any other option is there for this patient.
Dr. Gobind Babu has put in the chat box at 160 milligrams. So you're talking about TDM1, sir?
Osimertinib.
Okay, fine. Okay, a higher dose osimertinib. Okay.
So if the lead discussion permits, can I ask a question?
One option for lapatinib have ever been tried, like anybody tried in this patient, though this is quite rare and recently been now because we are doing NGS. So lapatinib after TDM1, anybody has tried?
So we could try probably positionib since it has some activity, though there are only small trials and after failure on TDM1, no data, but we if haven't had access. Lapatinib I have no experience, but in this scenario.
If the lead discussion permits, I have one question.
Yes, I think one last question.
Okay.
Because
so my basic question was in upfront, She is a banker, multiple comorbidities. So, so what we understood that we can do RT-PCR, a PCR technique by the or the NGS. Don't you think it would have been a smart, because the turnaround time is same, that we do a NGS in upfront? The second option was,
it would have been better, but we did not.
Yeah, so it would have been always better, and with time it will become cheap. Okay, you will get much more information, and rather than going in the upfront, you could have gone for a smaller panel, but whenever you do a biopsy, you should always go for a larger panel. You don't want to miss out anything. Second thing, I'm not sure, we should have gone back to the history. Did she took osimertinib regularly? See, at the progression at 4 months doesn't click. It is an expensive drug. So we are trying to cut corner on the PCR, and we are pushing a very expensive drug. So just see the paradox of a life. We'll go on doing testing, we'll go on pushing a costly drug. But the basic was, did she took the osimertinib or she missed out her drugs? Because she was in a multi-poly drugs. And what are the interactions which is happening with osimertinib, with so many things, so many drugs? I really don't know. I'm a rad on Nandini, Safalta.
Sir, I agree with you. I always send NGS first, because the thing is that we'll get multiple. One thing, NGS is very sensitive and a specific test. Plus, we are able to get other co-mutations if they are there. And I always doubted when I have seen this case. Within 4 months, the patient has progressed. That means there was some issue with the test. I did not agree this progression within 4 months. And,
I would have gone back in a history. I would have gone much more deeper to understand the polypharmacy and so many things, rather than doing. Okay, so it's an endless story. No, but I like the discussion of Nandini, Safalta, that we have 10 options, and Dr. Govind Babu has just subtly put that if you can escalate the dose, polypharmacy could have changed the pattern. I really loved you and the great discussion. I learned a lot here.
So I completely agree, sir, with you. Polypharmacy and compliance is a big issue. And the other thing what I found odd in this case is when we did the NGS, usually sir, certain mutation patterns are commonly seen after failure of osimertinib, like C797S or MET. Those were not seen, in a third, thing was found. So like you said, whether the question was the HER2 was present right at the beginning and we didn't detect it. I agree with you on these counts, and these things are evolving. And we are asking now more and more patients to do NGS upfront.
No, I am learning daily from you all. I'm so grateful to you all.
I think, great points raised by Agarwal. Thank you very much, sir. Absolutely right. This patient, we are sure about the compliance, but the right point about the polypharmacy and the interactions, that is something which we cannot discount. Yes, and I think the important message going out is that whenever patients can afford, it's better to go with NGS upfront. Very clear message, rather than doing it at a later stage like we did for this patient. And also thanks for all the great options suggested by all the panelists. I think I'll wind up now, the interest of time, over to the chairpersons.